So someone wanted to know about optic tract lesions and the presence of an RAPD. And one of the things that you need to know is a relative afferent pupillary defect tells us that there's a defect in the pupil pathway on the afferent side relative to the fellow eye, but it actually doesn't tell us which side the problem is on. So as you know from the pathway for the pupil, it starts when the light hits the retinal ganglion cell, travels on the optic nerve, and the nasal fiber crosses and the temporal fiber doesn't cross. And so you have a difference in the amount of fibers in the optic tract between the right eye and the left eye. So if this is the right eye and this is the left eye, you actually have more fibers from the nasal field, fiber from the right eye compared with the temporal fiber in the left eye. And that's because the visual field isn't actually a circle, it's an oval. And so the temporal field is bigger than the nasal field. And that means the nasal fiber actually is bigger than the temporal fiber. And that means relative to the fellow eye, when you have a left homonymous hemianopsia, you actually have more field loss in the eye with the temporal field defect. And so if you have a left optic tract lesion, you're going to have a right homonymous hemianopsia, and that means the field loss is actually going to be bigger in the eye with the temporal field defect, which in this case, in a right homonymous hemianopsia, is going to be the right eye. So that means if you have a lesion here in the optic tract on the left, you're going to have more damage to the nasal crossing fiber, which is the temporal field, and that means there'll be an RAPD in the right eye, even though the lesion is in the left optic tract. And that is counterintuitive because you want to say that an RAPD is always ipsilateral to the lesion, but it's not. It's only ipsilateral if you're in front of the chiasm. Once you're behind the chiasm, it can be either side. And there's this little interneuron that goes to the pretectal nuclei in the midbrain to the Edinger-Westphal, and that constitutes the efferent pathway. So you can still have an RAPD even at the level of the midbrain here with this pretectal nucleus. So we have RAPD in tract, it's on the side with the bigger field defect, and if it's a homonymous hemianopsia, that's usually died with the temporal field loss, which is the nasal fiber, which is from the contralateral eye. So left optic tract, right RAPD.